Okay, so welcome everyone to the Hospice 101 for Behavioral Health. We are really excited today to have Mary Kartes with us from Bristol Hospice. And I want to give you just a little bit of a training etiquette. So we want you to mute your mics, utilize the chat for questions and comments. You will receive a follow-up email with the slides, with a link to the recording and any other training materials that Mary or us feel like you would benefit from. And the CEUs are the CEU, one CEU today. You need to complete the survey that we will email you. And then also we get our evaluations done through PSU. And so there will be a separate just training evaluation coming from the IOA evaluation within the next few weeks. So if you can please complete there's going to be two surveys, one for your CEU and then one for your just a certificate of attendance. And of course, live attendance is required for the CEU. So you need to stick around for our entire training today. Let's see. Just to let you know, the Behavioral Health Initiative is a program that launched in 2015. We work to improve access to care from qualified providers for older adults and adults with physical disabilities across the state of Oregon. We do lots of collaborations. We build knowledge capacity through trainings like this, and then also community health and wellness promotion events. And we provide complex care consultations. So if you have a certain client, you can always reach out to either myself or Angela Jensen for Josephine County to work together on that. So our website is oregonbhi.org, and we are 2 of 24 specialists across the state. We have an upcoming training next month that is going to be really great, where it is called Living with Dying. We are talking about grief readiness for folks who support older adults in care settings or any sort of like social service support settings. And so that is going to happen October 10th, and that will go out with your follow-up email, the information on how to register for that. And that is also two free CEUs are going to be attached to that one. Okay, so I'm going to hand it over to Angela Jensen, and she's going to give our bio for Mary.
Yes, good morning, everybody. Thanks for joining us. We're thrilled to have Mary Kartes here, Executive Director for Bristol Hospice Rogue Valley, where she's been Executive Director since 2019 and played an essential role in the operational startup. Mary's working towards her Master of Science in Nursing, Leadership, and Management, has many years of leadership and clinical experience in community care, including skilled nursing facilities and home health. Prior to joining Bristol Hospice Rogue Valley, for many years, she held clinical leadership positions in Southern Oregon skilled nursing facilities, as well as home health. Of more recent, Mary was an Oregon regional nurse clinical consultant for skilled nursing facilities. She has a special heart for working with the senior population, providing care and support to patients and families. And when she is not at work, in her free time, she spends time with her family at the Oregon Coast Dunes, camping and playing on their ATVs, gardening, and enjoying the simplicity of home in Colonial Valley of Grants Pass. That, in a nutshell, is your speaker today, your lead speaker. She will have Rachel Somati Browning. Sorry, Rachel, for stumbling over that. Rachel will be helping her out in getting us some good info. We will have some folks joining along the way. There we go. There is our case management team, virtual. Thank you for finding that link Sorry for any confusion. I will help our others that aren't here that are trying to find their way. So I'm going to go off mic and let Mary take it away. Thanks, Mary.
Hello, thank you for having me. I just want to be sure that you are able to see my screen. I need to say share, don't I? There I am. I apologize for not having my camera on. I'm having a little bit of technical difficulties on my side. Thank you for that intro. I really appreciate it, Angela and Angela. So just to get started, yes, I am the RN Executive Director of Bristol Hospice Rogue Valley. We have started our program. We were a brand new, what they call a brand new startup, no employees, no patients, back in 2019, just prior to the COVID outbreak. So we are still trying to learn what is life without COVID, because that's how we started. As we go along, this is a Hospice 101. I do not work off of a script. I just talk along my slides. If you have any questions, please reach out. If we need to do a chat, if we need to look in chat, I'm sure Angela's will be looking at that chat. But as we go, definitely if you have questions, please reach out. So biggest piece was talking about palliative versus hospice. What is the difference and the nitty gritty surrounding that? So these can take, palliative versus hospice can have its own education. It is one slide, and palliative, just to give a quick diagnosis, quick description, palliative begins at the diagnosis and is provided alongside curative treatment. Whereas hospice begins after curative treatment has stopped and it is clear the patient is terminal. Palliative focuses on relieving suffering, and it's not time limited, where hospice focuses on comfort and support to live life as fully as possible until the end. And we are looking typically at a 6-month prognosis with that terminal diagnosis. So there's a difference between those two. The history of hospice started with Cicely Saunders in London back in, she started the first modern hospice in 1967. She had started working with the terminally ill in 48, and she believed in 3 things that continue to be the cornerstone or the foundation of hospice. And it's the need of strong relief from physical pain and troublesome symptoms, preserving one's dignity, guidance with the psychological and spiritual struggles that come along with death and the end of life. And so she had started St. Christopher's Hospice back in London, and it paved the way for hospice movement. So Cicely Saunders is just definitely somebody that we hold very dear to our heart in her start of this care. This slide is one that I always like to share and show to any kind of presentation that I'm doing. This really speaks volumes as to what we do. What kind of death do we want? Who do we want there? Who is it that, what kind of smells, sights, hearing, what is it that we want at the end? And so this slide is meant to represent, do we want to be in a hospital with all kinds of things connected to us? Or do we want to be at home with our special people and with music and with our animals and with soft lighting and aromatherapy? What is it that we truly want at the end? And so that's what we focus on in hospice, is what is it that we want at the end? Bristol Hospice considers itself the place of the bridge. It is where we journey over, we're bridging over. And I thought, you know, here in Southern Oregon, there's so many bridges. And so I just felt like it just really spoke to Bristol as a whole and the place of the bridge. And you'll see it up in the upper left-hand corner is the, they always call it, we call it the Bristol Bridge. This is a bridge that is located in England. It is the Clifton Suspension Bridge, and it is the marker for all of our branding is this bridge, and what it is just goes right alongside Cicely Saunders and her care in London. So what is hospice? We specialize in the care of those facing a life-limiting illness. We look at the disease trajectory, and it is a potential for the end of life to be 6 months or less. I always tell my folks when I'm going in to admit somebody to service, that doesn't mean that somebody won't live longer or that they'll live less. We just have to put a number on that. Medicare requires that we put a number on that. So it is 6 months or less. We address the patient's physical, emotional, social, and spiritual needs. And we provide help to patients, families, and caregivers. We come in and we wrap around that patient. We wrap around that person. And then along with that, we are wrapping around that family, around caregivers, around the facility, whomever may be close to that person. We're coming in and we're wrapping support around them. Care is provided to wherever the patient calls home, wherever that may be. It could be an adult foster care home. It could be an assisted living, memory care. It could be a private home. It could be those who are unhoused. It is wherever they find themselves at home. Hospice care believes in the quality of life to be as important as the length of life. So when patients are appropriate for hospice services, we had talked about that life-limiting illness. And if the disease follows its normal course, we're looking at an end of life to occur in 6 months or less. And when the focus turns to comfort care instead of aggressive treatments, that's when we determine that they're appropriate. So potential triggers for a hospice referral. We are looking at any and all of these items. We look at weight loss, and we say that 10% within the last 6 months, but we could see a 4% or a 5% in a month. We could see something that's happened in the last 2 to 3 weeks where appetite is decreased, intake is decreased, and we know that weight, we may not have a documented weight, but we know just based on that historics that there's going to be a weight change, right? So we look at those things. History of pneumonia, pressure ulcers, fever, urinary tract infections, refusing food and fluids, having difficulty swallowing, progressive decline in activities of daily living. All too often we see folks that were independent, living at home. Maybe daughter steps in once, twice, 3 times a week. They were independent and now they've suffered some kind of illness and they are no longer, they are bedbound, they are weak, they are tired, they're not getting out of bed any longer, or maybe they need extensive assist to get out of bed. So we're looking at that progressive decline. And then of course, reoccurrent emergency department visits and hospital admissions. So if we're seeing a lot of those, maybe we need to be having the discussion of hospice. Increased falls. We just talked about ADLs. So patient is dependent in at least 3 of these ADLs. So bathing, dressing, feeding, transfers, ambulation, and continence. If one is disabled or requiring special care and assistance or is unable to care for themselves and disease is progressing rapidly. Maybe they have some abnormal lab work. Maybe they have a cancer diagnosis and even after chemotherapy and or radiation is no longer futile, right? It's no longer working. Or one chooses to stop chemotherapy or radiation. One is severely ill, although death is not imminent. Fatal processes are progressing rapidly, very sick with active support treatment as necessary. So all potential triggers for a hospice referral. So who is hospice? Who are they? So registered nurse case manager, LPNs, we have hospice aides who are certified nurse assistants, social workers. On our team, we have 3 social workers, 2 of them are licensed clinical social work. Chaplain, we have 2 chaplains on our team. Volunteers, we have a volunteer coordinator and we have pet therapy and We have those who specialize in VA veterans. We just have this whole plethora of volunteers, and that continues to grow. We were impacted by COVID. Nobody was volunteering. We couldn't have volunteers. And so in the growth of Rogue Valley, Bristol Rogue Valley, we didn't have a good foundation of volunteers. And our new volunteer coordinator, Felicia, is doing a phenomenal job out in the community and helping to bring that to bedside. Obviously, the hospice medical director is part of that IDT, the attending physician, our bereavement coordinator, counseling services, but we also consider all of those other folks that are involved in the patient's care part of that IDT. And while it doesn't say it on this slide, it is folks like our caregiving agencies, our facilities, our folks like Journey Home Support Services. Those kind of folks are part of our IDT. While they don't come and attend our IDT meetings, they're part of us and we're collaborating with them. Who pays for hospice? It's always a big question. We always have that. We come in and we see our folks, and we're coming as a nurse when we're coming in to admit somebody to service. We're bringing in durable medical equipment and medications. And the question almost always first is, who's paying for this? So Medicare Part A pays for hospice at 100% at no charge to the patient if they have Part A benefit, right? Then we have Medicaid and then third-party insurances. I will say that a majority of the time our patients are Part A folks. Medication coverage. So the design of the Medicare hospice benefit was intended to cover virtually all items, services, and medications needed by the beneficiary electing the hospice benefit. So Medicare coverage is determined by whether or not that services are for treatment of a condition completely unrelated to the individual's terminal illness. So when we're looking at paying for items, how it relates to their terminal diagnosis and how and any of those comorbidities that relate to the terminal diagnosis. So I can say with certainty, with Bristol Hospice, we pay for 99% of medications. Durable medical equipment. Hospice pays for DME appropriate care in accordance with the patient's needs in hospice care. So things like a hospital bed, wheelchair cushions, specialty mattresses, suction machine, overbed table, bedside commodes. Did I say oxygen? I mean, all of those items as it relates to their terminal diagnosis and the comorbidities. Hospital beds are just such an incredible thing for our caregivers at bedside. A lot of our folks like to come home and they want to be in their own bed. And of course, we support that. Absolutely support that. But as things start to change and as one starts to have a change in condition and as folks start to transition, it becomes easier on the caregiver and less burden to be able to have a hospital bed to help with positioning one in bed. It also helps with independent mobility in bed. So we have things like side rails, trapezes. We do a high-low bed, so it goes all the way to the floor, helping with fall risk. So there's our durable medical equipment. Supplies. So Bristol Hospice provides all of our patients with their incontinence supplies, briefs, pull-up underwear, wipes, chucks, gloves, creams, lotions, any kind of wound supplies, Foley catheter supplies, intermittent cast supplies. All of that is provided by Bristol Hospice. Hospice benefit periods. So the first and second benefit period, and when one comes on to hospice, they have what they call, I'm going to back up a little bit, what they call benefit periods. And during that time, our IDT is consistently and constantly looking, does this patient still continue to qualify for hospice? We're always looking for declines. We're charting declines, which is for a lot of us is different than our normal processes because we're always looking for improvement, right? In other types of care, we're looking for improvement or maintenance. And in hospice, we look for declines of care. And so in those benefit periods, we are looking for that. And we have the first and second benefit periods that are 90 days in length. And then each subsequent benefit period thereafter is 60 days, and it requires a provider, a physician, a nurse practitioner, a PA to do a face-to-face visit to determine continued eligibility. Now, obviously, they're still doing that in those first two 90-day benefit periods, but they're not necessarily doing it face-to-face. It is based on what the IDT's assessment is. And then hospice revocations and discharges can affect benefit periods. So if I come onto hospice in my first benefit period, and in that time, maybe I've decided to revoke, maybe I'm not quite sure, maybe I want to just try one more time and see if there's anything else, I can decide to revoke that benefit. But my next benefit, I'm not going back into my first benefit period, I'm going into a second benefit period. So it can affect your benefit periods. So now that you know what hospice is, let's talk a little bit about symptom management. And I'll gloss over this. I don't know how many bedside clinical folks that I have on this call, so I'll gloss over this a little bit. We won't go into it. Yes. Yes.
Rachel, you are muted.
I muted myself as soon as I started talking. Are PeerWith available with hospice services yet? Is what the question is.
I'm sorry, I didn't hear the question. I apologize, Rachel. Sorry.
Are PeerWith covered by hospice service?
Not currently, not with Bristol. PureWics are not currently covered. That is something that we are considering. Yeah, that is not something currently that we're doing here. And I'm speaking for Bristol only. Okay.
Oh, thank you.
Yes. All right. Food and fluid at the end of life. So the desire and even the ability to eat and drink will decline as the patient's disease progresses. Forcing food and fluid can cause discomfort. And I have to tell you, this is probably one of the biggest pieces that we provide education with our families with. A lot of education surrounding food and fluid. So we always say, when coming on to hospice, you can eat and drink whatever you want. Whatever your dear heart desires, you get to eat and drink. But then as things start to change, families become, even caregivers, even facility caregivers, it becomes very difficult to see somebody start to withdraw and not to eat and drink. The one thing to remember is that we eat and drink for energy, right? It's so that we are able to have energy. And if we're not doing much, we don't need as much energy. So we encourage favorite food and fluids. We offer sips. We make sure that we're doing good oral care, that we're making mealtime pleasant. What does our normal mealtime look like? Do we have soft music on? Or are we sitting in front of the TV and with a TV tray? What is it that we typically do? We're offering smaller meals, smaller dishes. And so we are just finding other ways to help with appetite, but we don't force it. We do ask that our caregivers report, or even our patients report, the decreased ability to swallow, including coughing, choking, and pocketing food, decreased intake, unable to take meals, and sleeping through meals. Because again, this speaks to those declines that we're looking for. Fatigue, what is it that we can do? So encouraging rest is needed, planning rest periods during the day, energy conservation, assisting with ADLs. I won't read the whole slide to you, but I think the biggest piece is just encouraging rest. Agitation and anxiety. We start to see this a lot as folks start to have a change of condition and start to transition. We start to see that agitation and anxiety, and we try to stay right on top of that. It could be a sign that a patient is getting closer to death. Those symptoms look like fear, worrying, rapid breathing, shaking, sweating, pulling at sheets and covers, fidgeting, tension. And so we focus in on that, and we look at non-medication interventions to address that. And let me move the slide over. Doing things that have helped with anxiety in the past, like reading a book, watching a movie, helping with deep breathing. Maybe it is medication, offering reassurance, bed baths, soothing massage and music, and decreasing stimulation. A lot of us, a lot of folks, we have lots of people around the bedside. We'll come and there's all kinds of folks around the bedside, and we have a patient who's agitated. And sometimes it's just kind of helping those folks move away, still being near, but to move away, to maybe quiet the area, maybe put some music on, but maybe just decreasing the stimulation by even potentially having less visitors, dimming the lights, just focusing in on that. So here at Bristol, we have several programs that will help with some of those interventions. We have Bright Moments, Perfect Harmony, and Sweet Dreams. No other hospice in the Valley offers these programs, and it's to help with non-medication interventions. One of those is Bright Moments. Bright Moments had started out as a dementia-focused, and it even says that on this slide, for it is a dementia-focused program, but we've broadened that. We want anybody who can benefit from Bright Moments to be able to have Bright Moments. It's not just for our dementia folks. Bright Moments includes the TheraBear, which you can see him here in this picture. So the TheraBear, it's the tactile touch, being able to touch him and to pet him and to rub him. He's also aromatherapy bear. He can be placed in the microwave. He can be chilled. So he's either a warm or chill bear. We also, in our Bright Moments kits, include aromatherapy. What we do is we provide an assessment with our patient and with our families, and we ask questions in regards to aromatherapy. We ask questions about music. Music is a big deal with our Bright Moments. I don't know if anybody has ever watched the Alive Inside video or maybe the ballerina video, but our folks with, especially our folks with dementia, as soon as we turn on music of their genre, it changes that patient in so many phenomenal ways. And so we focus in on music, aromatherapy, the tactile touch with that bear. We have in that Bright Moments kit what is called a nosy cup, and I wish I would have put it on the slide. There's the nosy cup. It's a cutout for the nose. As folks start to change and as they have with dementia and with cognitive decline, we forget how to tilt our head back. And so this helps the small nosy cup with the cutout of the nose and able to where one can still sit upright and not have to tilt their head back and be able to drink from a cup. We have what is called a bubbler. It looks similar to a, Rachel, help me out, a lava lamp. Looks similar to a lava lamp. And we do definitely, when we're doing our assessment with those, is ensuring that those folks who have had agitation or severe behaviors before, we may not necessarily use that. But a lava lamp definitely helps with helping to calm. And then we have, last but not least, is a weighted blanket. And so in this picture of the bigger bear here, or the picture with the bear's forefront, this gal has a weighted blanket. Weighted blankets, there are clinical studies that indicate the use of those have definitely decreased the use of anxiolytics or anti-anxiety. So we use our Bright Moments as just, I'm just so passionate about it. And you'll see just in these two photos here, this is our pet therapy volunteer visiting one of our patients. And you see that bear there. And we've just seen so many wonderful impacts with this. We had a patient a couple of years ago where we introduced this. She was an incredibly dramatic gal, and just lots of behaviors in the facility. They were at their wits' end. They did not know what to do. They were asking for medications. And we introduced medications, but we were finding that we're giving these medications and then she would just be in a stoop. And that's not what we want to do. We don't want to squelch her, right? We don't want to squish that out. We want her to continue to be her person. And we found out as we continued to do our interviews that this gal had been an actress and been a singer. And so we did some more interviews and were able to focus in on the music. And once we had this music that was something that she preferred and we put that music on, she changed into a different person. She was who she was so many years ago. And so we were able to back off those medications and really use the Bright Moments kit as a way to help alleviate those behaviors.
And I'm going to jump in, Mary, so I can show off the kit.
Oh,
so this is our buffer. So the little lava lamp. And it really, really does help with bed baths. It helps with calming showers if people need that. It helps with changing all of the things. It's not something you want to give to someone who's already agitated because it does hurt. Yeah. But it does help at the same time. And then this is the nosy cup. So I'm keeping this one so I can show you. So when you put, it just goes right over your nose, right here. So that people don't have to tilt back or, it eliminates falls and choking and things like that. So that's the nosy cup. That's where your nose goes. This is our bear, live and in charge. Also slightly weighted. Not as heavy as the blanket, but it is slightly weighted and feels very, very good. I mean, hopefully I can come and do this presentation all by itself for you guys at some point. And then our blanket, which comes all bundled up like this in the package. And the whole kit also comes with the MP3 player. The music is changed out as often as people feel like it needs to. Dementia or not, after a while you get tired of hearing the same thing, okay? So we'll take it back, we wipe it clean and reload it with whatever the music. Yes, the bear can be warm. Whatever kind of music that family has been assessed that the patient loves or likes, or the patient has been assessed for. And then it also comes with a memory board, which holds different colors that the patient may love. If they loved horses and they lived on a ranch, then the memory board can include that. Different family members on that board. A lot of places that people it's not always conducive to have their beds close to windows, or windows are up a little bit higher, or you want that dimming sensation, so you kind of want the windows closed. So that memory board being somewhere where they can see it often is very, very helpful and extremely calming for people. In this kit, I'm sorry, I don't have it, but there's also, Mary hasn't gotten to this yet, so I think I'm jumping the gun. A maroon spoon, which has kind of a wider mouth to it. It's hard plastic, but maroon for dementia patients is the color that actually enhances them to want to eat. I can't exactly tell you why because I can't remember. However, that is also good for being able to give medication, small sips of water, small sips of juice, whatever that person likes, but to help eliminate that choking when they're taking pills or medications or taking sips of water. So I just wanted to be able to show you guys that live and in charge.
Thank you, Rachel. Appreciate that very much. Yes. So there you go. You saw that live in person. We are incredibly passionate about the Bright Moments kit and in the Bright Moments program. And again, we can do a whole presentation just on it. Sweet dreams. So this program is based on the belief that compassionate presence and provision of a care plan devoted to the end of day sleep rituals and comfort can enhance patient satisfaction. So we all have a routine when we're getting ready for bed. We all have this routine of, maybe we We go in and we brush our teeth. We might take a shower or a bath. We're maybe putting lotions on, maybe using a little bit of aromatherapy on our pillow. We're turning on maybe some rain sound or ocean sound, some sort of white noise. And so our Sweet Dreams kit comes with that. It comes with aromatherapy. It comes with music. And so we've have found, and when we initially started Sweet Dreams, we were really trying to focus in around bedtime hours. We had hired staff to be able to focus in on those bedtime hours, and folks didn't want to be seen in the evening. And so what we really have drilled down to is most of our folks are sleeping a lot, and bedtime is all day, every day. So Sweet Dreams is not just needed at the hour of sleep. It could be at any time during. So as we continue to talk about symptom management, shortness of breath looks like rapid breathing, a patient indicating that they're winded. They're not able to speak full sentences. They're sitting with their hands on the side of the bed and leaning over a bedside table. We call that tripod positioning. And lips and nail beds may be bluish in color and extremities may be mottled. So what can we do? We can allow the patient to sleep in the recliner. A lot of our COPD, respiratory distress folks sleep in the recliner. We encourage pursed-lip breathing, sitting by a window or a fan, encouraging relaxation techniques, continuing to be supportive. And of course, there's oxygen and then medication. Always looking at those non-medication interventions. So. Pain. So patient may verbally report pain, and pain is whatever the patient says it is. It's not up to us to determine, right? They'll have difficulty concentrating, change in eating patterns. And so nonverbal signs and symptoms of pain include facial expressions such as grimacing, frowning, or a wrinkled brow, restlessness, moaning, crying out, rubbing or guarding the place that hurts, labored breathing, looking scared or worried, wringing of the hands. So as we assess for pain, we're looking at how severe is that pain, where is it located, what makes it worse or better, the description of the pain, does it interfere with normal activities, do they have a pain goal, what medications the patient has taken in the past, and was it effective. So possible barriers to pain control include the patient's own beliefs, their own cultural, religious beliefs, societal attitudes towards pain management, caregivers' beliefs and bias, healthcare professionals' bias, family members' fear, completing a poor pain assessment, and then patients' prior experiences with pain management. Those are all barriers to pain control. So what can you do? So having a good medication regimen, offering relaxation techniques, distraction activities, heat and cold, aromatherapy, light massage, guided imagery. Again, looking at all those non-medication things first before we move on to a medication regimen. And with hospice comes always that word morphine. We're always worried about morphine. And I have to say, morphine is the most beautiful medication ever. It's incredibly useful at the end of life. It helps relieve pain and shortness of breath, and it does not hasten death. We hear stories out there that I know someone who was on hospice and they started morphine and they died 2-3 days later. It was the morphine. What the morphine does is it goes in and it helps to relax that person to let them go. And then we see tolerance happening when a person no longer responds to a drug. They did it first. If a patient has been on opioids for a long time or period, we may have to use a higher dose of medication to achieve the same effect. A lot of education towards morphine in our community. Nausea and vomiting, yes.
Sorry, it is something that I was going to say that same thing. It is something that we have to educate on all the time. And it's not just for caregivers, um, nurses, med techs out in communities, because everyone fears that they're giving that last.
You're on mute, Rachel. There you go.
Sorry, is not the case. So, I mean, when it comes to morphine and all the other hospice comfort medications, education is key, not just for those people in facilities, nursing homes, things like that, but also for home patients, because they also feel like, oh, I gave this small dose of morphine and then my mom passed away. Or, I know someone who went on hospice and they started morphine and they died 2 days later. Well, they were already on their way. They were already going to go. And all this medication does is, like Mary said, is ease the
Keeps muting herself.
So, giving yourself some ease when it comes to, if you have to ever give that medication, knowing that there's no way that you gave the last dose or the killer dose. You may have given the last dose, but not the killer dose. That was already in the works.
Yeah. Thank you, Rachel. Nausea and vomiting, that comes along too. And so we look at avoiding juices, fried foods, strong odors such as foods, perfumes, deodorizers. We offer sips of water and ice, carbonated beverages that have gone flat, smaller meals, and always looking at when was the last time they had a bowel movement, because nausea is a precursor to constipation. So we're always looking at that. And then, of course, there's always a medication regimen to help with it. Constipation. Constipation can be a side effect of pain medicine or other medications. A decreased food and fluids, decreased activity, decreased GI motility, and just the disease process. So what we do is we ask our caregivers to report change of bowel pattern, no BM in 3 days, reports of pain or cramping, blood in the stool, diarrhea, bloating, nausea, vomiting, and stool. We ask that folks keep a documentation of bowel movements, and of course, encouraging fluids and activity, frequent repositioning, encouraging to sit upright on a toilet. And then, of course, my biggest one is prune juice. Delirium. So what is it? It's a sudden change in a person's mental status over a period of hours to days. And this is a common occurrence at the end of life. So we ask that caregivers report a change in a patient's behavior, a reversal of sleep and wake cycles, sundowning or confusion that is worse at night, mood swings that change over the course of the day, hallucinations and agitation or irritability. So what can you do? Of course, keep the patient safe, reminding them that you're providing care to them, reminding them that you're there with them. Maintaining routine and structure, keeping a calm voice, in a peaceful environment. And then there's always a medication regimen to help with delirium. Skincare is a big one. Skin is the largest organ of the body, and it is the first to fail. And so our folks are at high risk for skin breakdown. So we are always looking at ways to decrease pressure, with repositioning and providing education to our families and caregivers. Skip that. So progression into transition and actively dying. So signs and symptoms of approaching death. We do not have we're not able to indicate when somebody is going to pass, but we have a pretty good idea just based on the signs and symptoms. So increased sleeping, speaking to people who are not present, talking about leaving or taking a trip. They start to withdraw. They're eating and drinking less. We've talked about that. Difficulty swallowing, constipation, increased confusion, incontinence, decreased urination, moist breathing sounds, breathing pattern changes. You might have cool feeling extremities. They might have a rally. We see folks where they suddenly rally. They're up, they're bright-eyed, they've ate a full meal, and almost inevitably family thinks they've turned the course. We don't need hospice anymore. And almost always that burst of energy is gone and they are passing within a day or a few days. And then of course, increasing fatigue. Signs of imminent death. We start to see modeling or cyanosis. We see an increase in respiratory rate, a decrease in blood pressure, apnea, minimally or non-responsive, pallor or dusky appearance, little or no urine output, dark urine, sunken appearance to face agitation, fever, and increased respiratory secretions. So communicating with a seriously ill patient or those who are imminent is just to listen and be present. Silence is okay. Just be in the space with them. Learning about the patient's history and current condition, creating a supportive environment, that just keeps coming up over and over again. It goes back to that same slide, that very first slide, one of the very first slides that I showed where you saw the gentleman hooked up to everything and then at home and peaceful, right? So creating a supportive environment, allowing time for conversation and not rushing care, being culturally sensitive, maintaining privacy and listening with full attention. So many ways of communicating with our folks. So we look at whole person care and meeting emotional and spiritual needs. Emotional and spiritual distress is, characterized by sadness and anger and despair, depression, anxiety, afraid to fall asleep, questioning their beliefs and feeling a sense of emptiness. And again, just we're there with hospice, we're there to just wrap around that person, family and caregivers, and to address those needs. Sometimes it's about resolving prior conflicts. Maybe they're estranged from their children or estranged from their parents, and just helping to navigate that. If we can't bring somebody together with those folks, and we have, we just help to be there and to be present in those times and to do a life review with them and to honor them and just again bringing in our social workers and our chaplains and just really having them wrap around to provide the care. I talked about volunteers earlier, so we have a big emphasis on our veteran population. I think we have just since January, we have been able to provide care to at least 115 veterans since January 1. So we're really dedicated to that. We are We Honor Veterans accredited program. We are the only hospice program that is accredited for We Honor Veterans. We are a level 2 and working on our level 3. And so that those levels are based on different things that the We Honor Veterans program has put in place to things like providing different types of services to our veterans. And so we just continue to work on focusing on our levels and achieving that.
Is that related to like helping utilize VA services for the veterans?
Sure, it can be. And it could be just a veteran to veteran volunteer. So we have veteran volunteers that will go because some folks have requested that. They want a veteran to provide care. And so, yeah, then we'll use those volunteers that are veterans to do that. There's all kinds of different criteria, Heather, and I couldn't even tell you all of that criteria. Our volunteer coordinator would be best to do that. Yeah. All right. Always self-care for the caregiver, right? We drag ourselves into the dirt, taking care of our loved ones. So remembering to take time to rest. When they're sleeping, we should be sleeping. Doing meal prep, spending some time alone. And that's where our volunteers and even our CNAs or any of our staff, there are times where somebody just has to get away. They have to go take a drive. Maybe they need to go grocery shopping. Maybe they have to attend to their own health needs. And so we'll come in and sit at bedside so that they are able to provide their own self-care. All right, so specifically for this group, we have the question of what does hospice look like for marginalized populations? And how do we support the seriously mentally ill, active substance abusers, and the unhoused? So I'm speaking in general of hospices in general, not specifically Bristol. It depends on the medical director's comfort with those folks. Also the IDT skill set and their comfort. And so now with Bristol, if we don't do it, who will? If we don't do it, if we're not out there and we're not providing the care to these folks, who's going to? Rachel will tell you, I don't say no. If we see a referral come through, we're doing everything as a team to make sure that we're providing that care. I just don't want to say no. I want to be able to provide that service to our community. And so what we do is we make sure that we're providing a solid plan when we're going to our medical director to look at admitting somebody to service. And what is happening when they start to transition and they're not able to provide their own care? Who's going to be there and how are we going to do that? What resources and community resources, our collaboration with those community resources. We have our hospice community liaisons. That's what Rachel is. Rachel is actually our area director for our community, so community development. And moving into that role just recently, she was a liaison. So she is the boots on the ground out in Josephine County. And she is very familiar with the community resources out there. And so we're using those, using our liaisons to help us with those resources. I will tell you that our medical director is if we have an active substance abuser, we don't necessarily use narcotic medications. We're very cautious with that. We try to work around it, and we see what is it that they're exactly using, and we try to work our care plan around that. You can be an active substance abuser and be on hospice, where our care plan is going to work around that and provide the best care that we can. So I had already talked about the review of the journey. So what resources are going to be there as we assist along the way? And then remembering that hospice is not primary care. We're not there to do the day-to-day cares, but we try to customize to the patient's needs and work around them as best that we are able. We'll increase frequency of CNAs in a typical hospice, a CNA goes out twice a week. We have 7-day coverage. So we'll take our CNAs out there daily if we need to. Our nurses will go out daily if we need to. We're constantly looking and customizing and changing our care plan to the patient's needs and work around that. And then our hospice IDT has specific annual cultural sensitivity training as well. So we meet our patients and families where they're at. If we don't, who will? So that's where we leave that. How does hospice collaborate with ALF and memory care partners in the community? Well, I talked about it. We have those hospice liaisons. They are our face in those communities, in those ALFs, memory care, SNFs, adult family care homes. They are there to help coordinate cares. And then we have another program that I had touched on earlier, was Perfect Harmony. And Perfect Harmony is really focused on regulatory standard for those programs or for those communities. And so we're making sure that we are collaborating with them and that we're following their regulation. And so Perfect Harmony, we go in and we do a bit of a case conference with the facilities and sit down with them and ensuring that our care plans we're collaborating our care plans, but that they're coordinated and that they match, and that medications meet regulatory standards, and so on and so forth. We just make sure, and it goes right into the title of it, is Perfect Harmony. And so again, no other hospice offers Perfect Harmony in Southern Oregon. So just continuing to collaborate and coordinate. There we are, right there at 11:55. Any questions?
Do you guys utilize the 5 wishes or some type of documentation to help patients when they want to do that kind of stuff?
Specifically, Are you talking about death with dignity?
No, Five
I am not.
Wishes is kind of like a are you familiar with it?
I am not.
Oh, it's really interesting. It's a pre-prepared document of kind of what your wishes would be, especially when we have difficulties with families, maybe coming to terms with everything going on, and the patient's decision to make the step with hospice or different things like that.
So
You can Google it. It's a very interesting
I
document.
love
It's
that.
very,
And
very,
I'll do
Yeah,
that.
it's very well worded.
I can talk on that for a second. So that is one of the ways that people are doing their advance directives.
Directive, yes.
Yet in Oregon, we do not have virtual signing capabilities on an advance directive. So the 5 wishes cannot be used as an advance directive in Oregon, but it can be used in creating that conversation framework. So oftentimes people will do the 5 wishes, but you still need to do your own advance directive specific to the state of Oregon.
Thank you,
And
Angie.
in some of the funeral homes, they actually have paperwork that is similar to that as well. So when people go in to set things up at the funeral home, it has a sheet that they fill out for their families as well with their wishes. It's like a few wishes and then a document that has all of their passwords and things like that. But I don't think it was called 5 wishes, but something similar is offered at the funeral homes around town here too.
Thank you. Excellent question. And definitely I need to do some research. Yes, we do a lot of work around the advance directive, obviously. Our social workers do as well as the full team. And then I had brought up the death with dignity. We definitely support that. We meet our patients where they're at and we support them in their care plan. And so we work with LCOR, End of Life Care Choices here in Oregon, to make sure that we are honoring patients' goals.
Does your medical director do any input with the death with, because I know they need a 2 MD signature, or do they just use the 2 physicians that are part of Death with Dignity if there's no primary?
Good question, Heather. Our physician, our medical director does not. That is a conflict of interest, so he cannot sign. Yeah.
So I have a couple of things I want to put out there. We have like 1 minute. Quick question to our case management team. Have any of you had an active client who was also receiving hospice care? And if so, how did you coordinate? Did you feel like you were able to make those connections with whichever hospice was providing services? And then Mary, can you talk about just real quickly how to make a hospice referral?
Sure.
How did those happen?
You call me.
Yes, so hospice referral, that is just, we do have to have a physician order. However, we don't need the physician order to go out and do an evaluation or an informational. So an informational is where our liaisons who are non-nurses will go out and provide information on hospice services. And it can come from, as long as you have permission, it can come from a caseworker. It can come from it can even come from the physician's office, from the discharge planner, whomever it may be. And we can go out and do an informational. And then a nurse can go out and do an evaluation to say, would this patient be eligible for hospice? We need an order to admit to services though.
So you are meeting folks wherever they call home, even if they're homeless, and
Yes, ma'am.
you will meet them at wherever they like to hang out
Yes,
to
ma'am.
provide services there.
Yes, ma'am.
Okay.
Absolutely.
Awesome. So for folks that need to jump off, go ahead and jump off. If Mary is able to hang out for a few minutes, then we can continue asking questions.
Wow, that was excellent.
Yeah.
Excellent info. A lot crammed into under an hour.
And I'm interested
Kudos.
in, like, when you guys email us stuff, I'd be interested in the information about volunteering, but specifically to, like, if someone is wanting a vet to volunteer with a vet.
Yeah.
Okay.
Absolutely.
I think, Mary, if you have anything, documentation, like a flyer or a
Absolutely.
brochure that we can send, we'll include
Absolutely.
that.
Yep. I'll go ahead and I'll pull a few of those resources, as well as I'll go ahead and pull the referral form too, just so that you have that. But I'll pull that
Cool.
as well as the
That's
volunteer.
Mary.
Absolutely.
I can get that sent over for you.
What's that?
Okay.
I can get that sent over for you, Mary. I'll do that right now.
Thank you.
Absolutely.
Great. Well, we want to thank everyone for coming today. And Mary, thank you for jumping in during your time off.
Oh, yes, of course. Absolutely.
Yeah.
Thank you.
And Rachel for helping coordinate this. And so we will be sending out the follow-up email and any other materials. And we really appreciate everyone. And if you have any sort of requests for any specific trainings, always send us an email and we can develop a training around those different topics that you are needing or seeing more education being beneficial. So yeah, okay. Thanks everyone. Have a good
Thanks,
day.
everybody.
Thank you so much, you all.